Epilepsy basically একটা CNS disorder রয়েছে. Epilepsy is a group of CNS disorder where due to the abnormal electrical discharge in the brain, the patient may manifest with motor phenomena or sensory phenomena or the psychiatric phenomena. Motor phenomena can be abnormal movement of the limbs, abnormal involuntary movement of the limbs, while sensory can be abnormal sensation or patient may show abnormal phenomena, abnormal behavior abnormalities. So these are the group of CNS disorders characterized by paroxysmal cerebral dysrhythmia. যেরকম আমরা হার্টে অ্যারিথমিয়া পড়েছি because of abnormal electrical conduction in the heart. Similarly, abnormal electrical discharge in the heart can lead to paroxysmal cerebral dysrhythmia, manifesting as brief episodes of loss or disturbance of consciousness with or without characteristic body movements. So these characteristic body movements we say as convulsion is the symptom we see, and the abnormal electrical discharge in the brain we say it seizure. And it can be not only motor phenomena, the patient may complain of abnormal sensation, that the sensory phenomena or abnormal behavior may occur during that episode. It depends on the focus of brain where the abnormal electrical discharge is occurring. It is unpredictable when it will occur, no one will able to say. So it is unpredictable and the frequency is highly variable. It may occur in months or in years, we cannot say, we cannot predict. Focal origin in brain, manifestation depend on the site of the brain where the electrical discharge, abnormal electrical discharge is seen, regions into which the discharge is spread and the post-ictal depression of these regions. Many of the cases are idiopathic, no cause is seen, and it can be even secondary in origin to the traumatic brain injury. It can be due to the brain stroke, malignancy or intracerebral space occupying lesions and many others. Treatment is symptomatic for any type of seizure. The treatment is same. Now types of epilepsy. Generally we divide the epilepsy into two broad groups. Number one is partial epilepsy, partial seizure, and the generalized seizure. Generalized seizure means the whole of the body is involved, and partial seizure means a part of the body. So generalized seizures can again be generalized tonic-clonic seizure. It is the most common type we encounter in regular practice. What happens in generalized tonic-clonic seizure? The patient become unconscious, there is tonic extension of the body followed by clonic movement of the body to and fro. Then comes the absence seizure. Absence seizure is commonly seen in children. There is a brief episode of unconsciousness where the child have a blank look. The child is telling something, suddenly the child stops for a few seconds and there is a blank look, and again the child starts talking. This is commonly seen in the absence seizure. The child who is having absence seizure, he cannot recognize his own deficit problems and it is seen by others. So these are absence seizure. It can be atonic seizure where along with unconsciousness there is relaxation of the muscle. So there is a tendency of fall. Myoclonic seizures, infantile spasms. And in the partial seizure, there is simple partial seizure where there is focal involvement of the body plus the consciousness is preserved. And the difference with the complex partial seizure is the consciousness is lost in the complex partial seizure. And it can be even simple or complex partial seizure with secondary generalization. Classification of anti-epileptic drugs. Number one is barbiturate, where we use phenobarbital. Number 2 is deoxybarbiturate having primidone. Then Hydantoin, Phenytoin is one of the commonly used drug. Phenytoin we use in status epilepticus, we will come to it later. Iminostilbene, Carbamazepine, one of the commonly used drug. Carbamazepine, Succinimide, that includes ethosuximide, it has efficacy in absence seizure. Aliphatic carboxylic acid, that includes valproic acid, is a drug which can treat all types of epilepsies. Divalproics, benzodiazepines, that include clonazepam, diazepam, lorazepam and clobazam. Phenyltrazine, lamotrigine, cyclic GABA analogs, that include gabapentin, pregabalin. Newer drugs that include topiramate, zonisamide, levetiracetam, vigabatrin, triagabine and lacosamide. Okay. Now today we will be discussing on the barbiturate, primidone, phenytoin, carbamazepine, ethosuximide, valproic acid and benzodiazepines. Now these are the chemical structure of classical anticonvulsant drug. Is the barbiturate having a 6-membered ring, and is the hydantoin, that is phenytoin, 5-membered ring, succinimide. Now mechanism of action of anti-epileptic drugs. There are 3 primary mechanisms. One, sodium channel, they act on sodium channel. They can act on the GABA gated chloride channel. GABA gated chloride channel কি কাজ করে? হ্যাঁ, কে কোন ড্রাগটা কাজ করে GABA gated chloride চ্যানেলে? হ্যাঁ সরি, বারবিচুরেট কাজ করে। আর কে কাজ করে? বেনজোডাইজিপিন কাজ করে, এটা পড়ে এসেছি আমরা অলরেডি সেডেটিভ চ্যাপ্টারে। হ্যাঁ, তো নাম্বার 1, prolongation of sodium channel inactivation. So one of the important target is sodium channel. What happens? We know sodium channel, they occur in 3 states. One is the open state, when the sodium channel is opened so that sodium influx can occur. Then after the channel closes, when the stimuli is over, sodium channel closes, temporarily it is in inactivation state where any stimuli will not open the sodium channel, and then the sodium channel is in closed state where the stimuli, if occurs, if there is a stimuli, the sodium channel will open up. Now what happens? These anti-epileptic drugs, they prolong the inactivated state of sodium channel. So these are done by phenytoin, carbamazepine, valproate, lamotrigine, topiramate, zonisamide, lacosamide. So it was one of the target. Then the next target is GABA gated chloride channel complex, chloride channel, sorry. So they facilitate GABA mediated chloride channel opening, done by barbiturate, done by benzodiazepines, done by valproate, vigabatrin, gabapentin, triagabine. And the third target is T-type calcium channel current. They basically inhibit the T-type calcium channel current, and these drugs which inhibit the T-type calcium channel currents, they are efficacious in, effective in absence seizure. These are done by ethosuximide, valproic acid, zonisamide. Now coming to the first group of drug, phenobarbital. Phenobarbital, as we know, is a barbiturate. As it is a barbiturate, so it acts on the GABA gated chloride channel and facilitate and basically increase the chloride channel influx. So it acts primarily at the GABA gated chloride channel complex and potentiate GABAergic inhibition by increasing the lifetime opening of the chloride channel. It has specific anticonvulsant activity which is not entirely dependent on general CNS depression. Now it has got a wide spectrum of anticonvulsant property with continued use. যখন আমরা ইউজটা কন্টিনিউ করব, sedation effect gradually wanes off, but the anticonvulsant property persists. Now sedation is the major side effect. Long-term administration can lead to behavioral abnormalities, diminution of intelligence, impairment of memory and learning in children, hyperactivity, mental confusion in the older people. They are used primarily in the generalized tonic-clonic seizure and the partial seizure, simple and complex partial seizure. This has been infrequently used in children nowadays because of impairment in learning and memory, and may be used potentially in status epilepticus, but their use has been declined now because of availability of the more safer drug and newer and more safer drugs. Now coming to the next drug, Primidone. It's a deoxybarbiturate. It again acts on the GABA-gated chloride channel, converted by liver to phenobarbital and phenylethylmalonamide. Its anti-epileptic property depend on its active metabolites because the half-life of Primidone is 6 to 14 hours. Then the half-life of the active metabolites are longer. Anti-epileptic efficacy is similar to that of phenobarbital. These drugs are seldom used nowadays in GTCS and partial epilepsies because of the availability of Phenytoin, Carbamazepine and Valproic Acid. Adverse effects similar to that of phenobarbital. Now coming to the Phenytoin, it is one of the commonly used drug in epilepsy nowadays. Now it was synthesized in 1908 as a barbiturate analog for sedation purpose, but the drug was withdrawn because of lower efficacy. It was again reintroduced in the market in 1938 because of its efficacy as epileptic drug, anti-epileptic drug. Till recently, it is one of the major anti-epileptic drug used. It is not a global CNS depressant drug like that of barbiturate, but has got anti-convulsant property and has got mild sedation only at therapeutic dose. How does it act? Its primary action is on the sodium channel. It prolongs the inactivated state of sodium channel. Number one, at higher dose, it can also depress the presynaptic release of glutamate, facilitate the GABA release and reduces the calcium influx. But these actions require higher concentration and their contribution to the therapeutic action is uncertain. Its ability to selectively suppress high frequency firing confers efficacy in trigeminal neuralgia. Trigeminal neuralgia তে কি হয়? Here basic, not migraine. Migraine is different. It's basically, sorry? No. It's basically an abnormal electric shock-like sensation which occurs in the trigeminal distribution in the face. That occurs basically commonly due to the blockage of the vessel supplying the trigeminal nerve. Okay. So basically the drug Phenytoin is also helpful in the trigeminal neuralgia and in cardiac arrhythmias. So if the question is asked in the exam or in the viva that tell me the use of Phenytoin other than as anti-epileptic, then it can be trigeminal neuralgia. Trigeminal neuralgia the drug of choice ki, it's not Phenytoin, it's Carbamazepine. We will discuss. Okay, so it can be used in trigeminal neuralgia and in cardiac arrhythmias as well. And so the cardiac হয়েছে হার্টটা হয়নি না, ঠিক আছে। Now bioavailability of different market preparation may differ. মানে same drug of different brand, their efficacy or bioavailability may differ. So if the patient on Phenytoin is stable with a particular brand, it's better not to change. Bioavailability of different market preparation may differ. Now metabolized in liver by hydroxylation involving CYP2C9 and 19 as well as by glucuronidation conjugation. Now kinetics of metabolism, very important. Kinetics of metabolism changes, it is capacity limited and changes from the first order to zero order kinetics. Why? Because of saturation of the metabolizing enzymes. So what happens, as the dose of the drug is increased, the concentration of drug in the plasma rises exponentially and the toxicity chance is very high. So this drug basically lies in narrow therapeutic range. So the kinetics of metabolism changes from first order to zero order over the therapeutic range. As a result, a small increment in dose produce disproportionately rise in plasma concentration. Plasma half-life is 12 to 24 hours at therapeutic levels, but it rises progressively up to 60 hours when plasma concentration rise above 10 microgram per ml, because metabolizing enzymes get saturated. Monitoring of plasma concentration of phenytoin during therapy is better, is helpful in adjusting the dose. Adverse effect, the commonest adverse effect with phenytoin is gum hypertrophy. It is commonly seen in younger individual and can be prevented by good oral hygiene. It occurs due to overgrowth of gingival collagen fibers. So these are women suffering from the gum hypertrophy due to the use of phenytoin. Hirsutism, acne and the coarsening of facial features. This can also occur and those can be troublesome in the young girls. There is a girl suffering from hirsutism. Hirsutism means abnormal growth of hair. Hypersensitivity reactions can be seen that can be characterized by fever, drug-induced lupus erythematosus DLE, rashes, lymphadenopathy, neutropenia, but requires discontinuation of the therapy. যদি দেখা যায় একটা পেশেন্ট on phenytoin lymphadenopathy নিয়ে এসে বা neutropenia develop করেছে, fever or rash, the drug should be discontinued immediately. Megaloblastic anemia may occur because it interferes with folate absorption. It can lead to osteomalacia on prolonged therapy because of interference with vitamin D activation. During pregnancy, if the drug is used, it can lead to Fetal Hydantoin Syndrome. So it has got teratogenic potential. It leads to Fetal Hydantoin Syndrome characterized by hypoplastic phalanges, cleft palate, cleft lip and microcephaly. Now overdose toxicity, if the drug is used in higher doses, it can lead to cerebellar toxicity, vestibular toxicity. That can lead to ataxia, dizziness, nausea, vomiting, nystagmus, diplopia, drowsiness, behavioral alteration, mental confusion, hallucination, disorientation and rigidity can occur because of CNS toxicity, epigastric pain, nausea, vomiting. Intravenous injection can lead to intimal injury leading to intimal damage, thrombosis of vein. The site becomes edematous, discolored. Tissue necrosis occurs if solution extravasates. এটা বলার কারণটা এটাই রয়েছে because the another drug phosphenytoin. Now previously if a patient was having status epilepticus মানে কি, একটা পেশেন্টের recurrent episodes of seizure হয়ে যাচ্ছে and in between the episode the patient is unconscious. That is a medical emergency and the convulsion has to be basically stopped immediately. And for this one of the drugs that was used previously was phenytoin, but the problem with phenytoin was local tissue injury. Now with the use of phosphenytoin, which has got lesser intimal injury, the phosphenytoin has replaced phenytoin. Okay, so phenytoin on intravenous injection may cause local vascular injury. So the questions may come, why phosphenytoin is preferred over phenytoin in a patient of status epilepticus. This is the reason. Intravenous injection may cause local vascular injury leading to intimal damage or thrombosis of vein, edema, discoloration of the injected vein. Tissue necrosis occurs if the solution extravasates. And again, hypotension, cardiac arrhythmia can occur on intravenous injection. So the patient, if the patient is given phenytoin intravenously, then definitely continuous ECG monitoring should be done. Interaction is a potent inducer of CYP2C8-9 and CYP3A4-5 isoenzyme. It competitively inhibits CYP2C9 and 19. Now phenobarbital competitively inhibit phenytoin metabolism, while by enzyme induction both enhance each other degradation, and the final effect basically is unpredictable. Carbamazepine and phenytoin induces each other metabolism. Now valproic acid, it displaces phenytoin from the protein binding site and decreases metabolism. So plasma level of phenytoin increases. Now it has got interaction with chloramphenicol, isoniazid, cimetidine, warfarin, and then failure of OCP may be seen if the OCP is co-administered with phenytoin. Uses: it is commonly used in generalized tonic-clonic seizure, in the partial and in the simple and complex partial seizure. The problem with these drugs are frequent side effects, numerous drug interactions. A small increase in dose can lead to severe toxicity, can exacerbate absence and myoclonic seizures. It is because of this nowadays newer safer drugs are being preferred over phenytoin. Status epilepticus, phenytoin sodium is used intravenously only when phosphenytoin is not available. Trigeminal neuralgia is the use of drug other than epilepsy. Trigeminal neuralgia is the second choice drug to carbamazepine. Drug of choice in trigeminal neuralgia is carbamazepine, but phenytoin can also be used. Phosphenytoin is the water soluble prodrug of phenytoin. So drug is converted to phenytoin in the body. Introduced to overcome difficulties in intravenous injection of phenytoin. It has practically replaced phenytoin in status epilepticus patients. It is rapidly converted to phenytoin. The doses are expressed in phenytoin equivalent. 100 mg of phenytoin is equivalent to 150 mg of phosphenytoin. Less damaging to the intima, already said previously, only minor vascular complications are seen, and it can be injected at a faster rate, 150 mg per minute, while phenytoin can be injected maximum at the rate of 50 mg per minute. Continuous ECG is required even with phosphenytoin because it can lead to cardiac complication and hypotension. While phenytoin cannot be injected in a drip of glucose solution, it can precipitate. Phosphenytoin can be injected with both saline and glucose. Now coming to the next drug after phenytoin, carbamazepine is chemically related to imipramine, introduced in 1960 for trigeminal neuralgia, but soon it was being used for epilepsy. Pharmacological action resembles those of phenytoin. Action of sodium channel is similar to phenytoin. So, like phenytoin, it prolongs the inactivated state of sodium channel, exerts lithium-like therapeutic effect in mania and bipolar mood disorder. So, the action of carbamazepine other than epilepsy in the mania and bipolar mood disorder. ठीक है? It has also antidiuretic action, probably by enhancing ADS action on the renal tubules. Overall absorption slow, 75% plasma protein bound. In liver, it is metabolized to one of the active metabolite 10,11 epoxy carbamazepine, as well as by hydroxylation and conjugation reaction, substrate as well as inducer of CYP3A4 and CYP2C9. So the carbamazepine, when continued for a prolonged duration, it enhances its own metabolism, that is called auto-induction, and thus the half-life decreases on prolonged use. Adverse effect, common adverse effect is dose related neurotoxicity. It can lead to dizziness, sedation, vertigo, diplopia and ataxia. Use of extended release oral tablets can overcome these problems. Vomiting, diarrhea, worsening of seizure can be seen with higher dose. Acute intoxication can lead to coma, convulsion and cardiorespiratory collapse. Hypersensitivity reaction can be seen with this drug even, leading to fever, rashes, photosensitivity, hepatitis, DLE and rarely agranulocytosis and aplastic anemia. Water retention because of ADH like action, water retention hyponatremia can be seen in the elderly. So, to be used cautiously in elderly subject. Increased incidence of minor fetal malformation, but when carbamazepine is combined with valproic acid in a pregnant mother, the toxicity to the fetus is very high. Carbamazepine is an enzyme inducer, can reduce efficacy of haloperidol, OCP, lamotrigine, valproate and topiramate. Metabolism of carbamazepine is induced by phenobarbital, phenytoin and vice versa. Uses is the most effective drug for complex partial seizure. Complex partial seizure, a drug of choice is carbamazepine. Okay. So, it is the most effective drug for complex partial seizure and it also very commonly used for simple partial seizure and GTCS. However, it can exacerbate myoclonic, absence and atonic seizure. So, they are not used for atonic seizure, for myoclonic seizure and for the absence seizure, not even phenytoin. Now, drug of choice in trigeminal and related neuralgias, they are not useful. They are only useful in trigeminal neuralgia and not in any other type of neuralgia like diabetic neuropathy, traumatic neuropathy and others. They are used as an alternative to lithium in manic depressive illness and acute mania. Okay. So, what is the mechanism of action of phenytoin? Now, coming to oxcarbazepine. Now, is a newer congener of carbamazepine. What happens? Toxic effect due to the epoxide metabolite in liver of carbamazepine are avoided here. Drug interactions, auto-induction of own metabolism are less marked. Risk of hepatotoxicity is lower with oxcarbazepine than carbamazepine. Indications are same and better tolerated. Dose to dose, it is 1.5 times less potent. Carbamazepine is the S enantiomer of the S enantiopia prodrug. It is very rapidly converted to the active metabolite as is oxcarbazepine. Therapeutic and toxic effects are same, but it is suitable for once daily dosing. It is used as an add-on drug for simple partial seizure for the generalized tonic-clonic seizure. Ethosuximide basically it acts on the T-type calcium channel and they are effective only in absence seizure. So, clinically it is effective only in absence seizure. Primary action appears to be exerted in the thalamocortical system. It selectively suppresses T current without affecting other types of calcium or sodium currents. Now, uses absence seizure a drug of choice ki is sodium valproic acid, but ethosuximide is also effective and also approved for use in myoclonic seizure. So, myoclonic seizure use kora jete pare eta. Now, coming to the valproic acid, it is effective in all types of epilepsies, be it partial seizure, be it GTCS, be it akinetic absence seizure myoclonic epilepsy. It's a branch chain aliphatic carboxylic acid with a broad spectrum anti-convulsant action. It is effective in partial seizure, in GTCS, as well as in absence, myoclonic and atonic seizure. At anti-convulsant dose, sedation is very little with other central side effects. Mechanism of action, এটা বিভিন্ন epilepsy কাজ করতে পারে, so it has got a diverse mechanism of action. It acts on the sodium channel, it acts on the T current calcium channel, it acts on the GABA gated chloride channel. So a phenytoin like frequency dependent prolongation of sodium channel inactivation is the number one mechanism. Number two, weak attenuation of calcium mediated T current, Succinimide like. Enhanced release of inhibitory transmitter GABA due to inhibition of its degradation, as well as probably increasing its synthesis, increasing the synthesis of glutamate as a GABA from glutamic acid. Blockade of excitatory NMDA glutamate receptors is the other mechanism. So these are the four mechanisms by which valproic acid is acting. Pharmacokinetics, oral absorption good, protein 90% plasma protein bound, metabolized in liver and excreted in urine, plasma half-life 10 to 15 hours, but anti-convulsant effect lasts longer. Adverse effects, anorexia, vomiting, loose motion, heartburn, drowsiness, ataxia and tremor can occur at high dose. Alopecia, curling of hair, weight gain and increased bleeding tendency can be observed. Rashes, thrombocytopenia, infrequent but can be seen. And the most important complication with valproic acid is rise in serum transaminase leading to hepatotoxicity. So asymptomatic rise in serum transaminase often noted. Monitoring of liver function on valproate therapy is advised. Rarely fulminant hepatitis occurs in children, especially below 3 years. During pregnancy, what are the teratogenic effects? It can lead to spina bifida and other neural tube defects. So it should be avoided. Uses is drug of choice in absence seizure, one of the first line drug for partial seizure and GTCS. Most effective drug for myoclonic seizure. It is also useful in atonic seizure in which response is incomplete but is the drug of choice. And other than epilepsy, what are the uses of sodium valproic acid? It can be used alternative to lithium in mania, in bipolar illness. It has also been used in panic attacks. It can be used in migraine for prophylaxis. Interaction, it increases level of phenobarbital and lamotrigine by inhibiting their metabolism. It displaces phenytoin from its protein binding site and thus phenytoin toxicity may be seen. It inhibits hydrolysis of active metabolite of carbamazepine. Concurrent administration of sodium valproic with clonazepam is contraindicated because it can lead to exacerbation of absence seizure. Absence status may be precipitated. Fetal abnormalities are more common if sodium valproic acid and carbamazepine are combined. Now coming to divalproics. Divalproic is basically a combination of valproic acid and sodium valproate in 1:1 mixture. What is the advantage? The gastric tolerance is better. So the drug is commonly used in mania and bipolar illness, but may be used in epilepsy like that of sodium valproate. Now coming to the benzodiazepines, number one, clonazepam. Clonazepam is a benzodiazepine with anticonvulsant property. As benzodiazepine, it potentiates GABA gated chloride channel complex, and then pharmacokinetics, it has got a long duration of action around 24 hours. Adverse effect, because it is benzodiazepine, the major side effect is sedation and dullness, minimized by starting at low dose. If the drug is continued for a prolonged duration, the sedation basically gradually wanes off. So, tolerance develops to chronic therapy, lack of concentration, irritability, temper and other behavioral abnormalities can be seen in children. Motor disturbance and ataxia are dose related. Usage primarily employed in absence seizure. Also useful as an adjunct in myoclonic and akinetic epilepsy and can be used in infantile spasm. Value limited by basically development of tolerance. যদি ড্রাগটা 6 months or more continue করা হয়, then the basically the efficacy, anti-convulsion efficacy decreases. Also used to suppress acute mania. Clobazam basically it's 1,5-benzodiazepine. It has useful anti-epileptic property in partial secondary GTCS and in absence and atonic seizure, including some refractory case. Side effect profile is similar to that of benzodiazepine. Mechanism of action in the GABA-gated chloride channel complex. Sedation, psychomotor retardation less prominent. Used as an adjuvant to other anti-epileptic drugs. Coming to diazepam. Diazepam is used in status epilepticus patients. So, it is the first line drug for emergency control of convulsion. যখন convulsion একটা patient status epilepticus নিয়ে এসছে, to control the epilepsy first, we use benzodiazepines and 2 drugs are there for that, diazepam and lorazepam. Today, lorazepam is preferred over diazepam. We will come to that. Diazepam is the first line drug for emergency control of convulsion. For example, status epilepticus, tetanus, eclampsia, convulsion, drug poisoning. They are not used for long-term therapy. Why? Because of prominent sedative action and rapid development of tolerance. Now, thrombophlebitis of injected vein is common. Marked fall in blood pressure and respiratory depression can occur. So, the patient should be treated with diazepam when resuscitative measures should be at hand before the drug is given, so that if any respiratory depression occurs, that can be managed simultaneously. Rectal instillation of diazepam is now the preferred therapy for febrile convulsion in seizure. Ekta bachcha, febrile convulsion means it generally occurs in children below 5 years, where because of fever, when the temperature rises, the convulsion is seen. Now, in those cases, to control the convulsion, per rectal diazepam is the preferred drug. Lorazepam is again suitable as a first line therapy for status epilepticus. It is preferred over diazepam. Why? Because of lesser local thrombophlebitic complications and more sustained action. So, আজকে আমরা এটা valproic acid, phenytoin, carbamazepine, benzodiazepines এটা মেনলি করেছি। নেক্সট ক্লাস আমরা বেসিক্যালি নিউয়ার অ্যান্টি এপিলেপটিক ড্রাগসটা নেব and management of status epilepticus.